Good morning, good afternoon, and good evening to all our listeners and participants for this webinar on Midwifery Models of Care and on this International Day of the Midwife. I would like to wish you all a very happy International Day of the Midwife. And thank you for joining us. I can see that people are still joining us, but we will slowly start. It's 1 minute past and we will slowly start. So my name is Ulrika Renström-Loy. I'm a technical officer at WHO, and I'm so delighted to be here today with all of you on this International Day of the Midwife. So today, I think it's a super day to remind us that improving maternal and newborn health is not just about increasing access to services. It's really about quality of care and how care is organized and how care is provided and how women and families experience our care. Because more and more we understand that it's also that positive experience of pregnancy and childbirth that has a huge impact of the mother and the newborn. And we know that in some settings, women and newborn, they struggle to get timely and essential life-saving intervention. And in other settings, they are exposed to unnecessary procedure, unnecessary C-sections and other interventions. And this imbalance, it continues to drive preventable mortality and morbidity, while undermining the quality and the experience of care. So midwifery models of care that we will be talking about today, we know it's an effective and adaptable approach. And these models, they really place the competent midwives as the primary provider through pregnancy, childbirth, and postnatal care. And these models, they focus on person-centered care and respectful care, and it prioritizing natural processes and using interventions only when it's necessary. And we are getting more and more evidence that show that when women receive this continuity of care from a known midwife or a team of midwives, the outcomes improve and we have more efficient use of resources. So today we will talk about midwifery models of care, and we will move from concepts. We will share the WHO guidance documents and the concepts, and then we will move to practice and hear from our panelists from different countries, different settings on how they have organized their models of care in their countries to really fit for purpose and to meet the women's needs. So we are super happy to have colleagues joining from all the regions here today, and we have panelists from Australia, Ethiopia, South Africa, the Netherlands, and Sweden. And they will share how midwifery models of care are being put into practice and scaled in their countries. And I hope that we will all learn from their processes. But to open our session, I would like my colleague Amanda to go to next slide. And we can quickly go through the agenda to see how it will look like today. So we will first listen to Dr. Tedros, the Director General for WHO. He has made a recorded message for all of us on this day. And then I will move to my supervisor, Dr. Alison Moran, who is the unit head of the unit where I work at WHO. And then I will share our WHO guidance documents. And we will also hear from Professor Jane Sander about evidence and global framing. And she will also go a little bit deeper into models of care, so we get an understanding of what we mean with those two models. And then we go to the nitty-gritty, the interesting, which is our panel discussion. And then we also have time for you to ask questions. And you can ask questions anytime. You just use the Zoom Q&A booth. There is a box there, and you can write your questions there. And at the end, we will have a summary and key messages from Professor Jane Sandel, and then we will close it. So this is what will happen during the 90 minutes we will be together. But to start now, then I will ask Amanda to share the video from Dr. Tedros. Over to you, Amanda, to share the video.
Midwives play a crucial role in providing high-quality care for women, newborns, and adolescents. It's estimated that universal high-quality midwifery care in all countries could save up to 4.3 million lives annually by 2035. To realize that vision, WHO is supporting countries to transition to sustainable midwifery models of care, where midwives are the main providers for women and newborns from before pregnancy through to the postnatal period. Midwifery models of care are a cost-effective investment in equity, gender equality, and universal health coverage. And thank you all for your commitment and dedication to maximizing the role of midwives and creating a healthier future for women, newborns, families, and communities.
Ulrika, you're on mute.
Unmute.
Sorry. So let me now then go over to Dr. Alison Moran, our unit head. She will offer us a few welcome remarks. So over to you, Alison.
Great. Thank you. Thank you so much, Ulrika. And thanks very much to Dr. Tedros for those inspiring words. And I just want to wish you all a happy International Day of the Midwife. It's so wonderful to see so many colleagues online from every part of the world. So this is really a day to celebrate you and all the hard work that you do to improve the health of women and their babies. So thank you from us at WHO for your commitment and longstanding work to really make this a reality. So just to echo a few of the things that Ulrika has already framed, we're very excited today to have the opportunity to really talk with you about this concept around midwifery models of care, as Ulrika outlined, and think together and learn from each other about how this can be operationalized and institutionalized in different contexts around the world. So this is really a great moment to think together on how we can focus on how we can improve the quality of maternal and newborn care around reorganizing services and systems to ensure women have access to continuity of care during pregnancy, birth, postnatal period, and for their babies. So that's what we want to focus on today. We don't want to have a lot of talking at you. We want to make this a conversation so we can learn from each other about how we can move this agenda forward together. Ulrika will present some of the evidence that we've published as WHO, and we're so honored to have Professor Jane Sandel as well to help frame that evidence and think together about some of the research gaps as well moving forward. So as Ulrika said at the beginning, the midwifery models of care is really about how to support our colleagues in countries based on country priorities to organize the care for maternal and newborn health in a different way that will support cost-effective, quality, and coordinated care, where midwives can provide care to the full scope of practice along the continuity of care to ensure timely assessment when needed, and escalation and referral through clear pathways and strong team-based collaboration. In addition, looking at the use of appropriate evidence-based use of intervention, avoiding both underuse and overuse so that we can really maximize person-centered quality care. And when these elements are in place, the evidence is clear. We see better health outcomes, including fewer unnecessary interventions, better experiences for women and their families, and more efficient use of resources and more cost effectiveness. So I'm very pleased today that we'll hear from colleagues working all around the world and different regions, showing what it takes to really make that transition a reality and to scale these models in practice. Thank you again for joining us, and I'm very much looking forward to the discussion and to learning from all of you today, and to continuing to think how we move the discussion forward together to improve outcomes for women and their families. Thanks very much, and back over to you, Ulrika.
Thank you so much, Alison, for your words. So before we then go to the panel discussion, I would like to take a few minutes to share about evidence, like Alison said, but also about our guidance document. But first, I want to introduce you to our co-moderator, my dear colleague, Professor Jane Sandel, that is from the Department of Women and Children's Health, the Faculty of Life Science and Medicine at King's College in London. So very much welcome to you, Jane. Would you like to say hi just to the audience before we start with the presentations?
Hello, everybody. I'm honored to be here. It's a wonderful day. And I'm really looking forward to hearing what our panelists have to tell us. Thank you.
Thank you so much, Jane. So, Amanda, next slide. We go to look into the case and the evidence for midwifery models of care. So, across the world, countries are recognizing that it's important how maternity care is organized, and that it has a profound impact on health outcomes and on women's experience and on equity. So in 2024, WHO, together with many partners, published the global position paper on transitioning to midwifery models of care. And you can see the front page of the document here on the slides. And this position paper sets out the why midwifery models of care are essential for strengthening quality of care. And here on the slide, you can see the summary of the case for midwifery models of care, the rationale for transitioning to midwifery models of care, and why this shifts matter for health systems. So you can see that it improves health and well-being. It's a very humanized care, a more one-to-one care, and contribute to better society. But we have also seen from the evidence that it's a cost-effective intervention. And we will come to all these a little bit later in the webinar as well. So we can go to the next slide. So since 2024, when we published the position paper, we have worked very closely with our partners like UNFPA, UNICEF, ICM, GPIGO, and also many other partners. And we have developed a set of key documents on midwifery models of care. So you can see here the globe, there that we have the position paper that defines the why. It also presents the evidence, the definition, and the guiding principles. And then we have something that we call implementation guidance, that is the midwife's hand on the pregnant woman's belly to the left. And this document, the implementation guidance, it really tells you how to implement. It's trying to be like a practical tool, a technical tool on how you can transition to midwifery models of care. Then we have a third document that it's an advocacy document, and this one is called the Global Midwifery Accelerator. Okay, so we are seeing a real momentum now, and on this slide I also present the guidance documents that we have developed with the QR codes. So you can scan the QR code and access these documents online. And after this webinar, we will share the recording with you, and we will also share all these guidance documents. So if you don't have time now to scan and to find these documents later, you will receive an email with all these documents. Okay, I think we can go to next slide. So let's look at the definition that we have presented in the position paper. What is it that we mean when we say midwifery models of care? So midwifery models of care is designed to optimize service delivery or provision of care. So to really meet the needs of women and newborns across the continuum. So from pre-pregnancy to pregnancy, intrapartum and postpartum. And it's really to support women and newborns to receive the right care at the right time and from the right level of the provider. And one thing that is important is that evidence has shown that the best results are achieved when the same midwife or a team of midwives provide continuity of care across the pregnancy, birth, and postnatal period. So we can go to next slide. So here I just wanted to show that midwifery models of care can be delivered at different platforms. So it can be community-based. It can also be hospital-based, like birth centers. And it can be a public and or private care. And it can also be in resource-limited environments, even in humanitarian and crisis settings. And you will hear from our panelists more about this. And also, midwifery models of care can work in all contexts. So they can be adaptable as long as the principle is that the midwife is the main care provider. And of course, working interprofessionally with the obstetrician, nurses, pediatricians, and other providers. And these are the different models that we have presented in the implementation guidance, but there are so many others. Each country will adapt and adopt what fits for their context and their health system and their midwives. Okay, so I think I will give over to you now, Jane, to speak a little bit about the birth centers that I meant and continuity of midwife care. So over to you, Jane.
Okay, thank you, Ulrika. So we've had, I think this is the most common question that we have had, and which sparked off the importance of doing this webinar today. So we're talking about midwife units or birth centers. There are many names, different names that people use for these settings. But birth centers or midwifery units, they're dedicated places where women and babies who have no complications receive care provided and coordinated by midwives. So while they provide intrapartum care, they can sometimes offer other services as well. And they can either be what can be called freestanding, where they're located outside a hospital setting with the facility to refer women and babies to a higher level facility, or they can be located in a hospital setting alongside an obstetric unit. So that's one type of model of care. The other type of model of care is what we call continuity of midwife care. So this is where care is provided from the same midwife in a team by a team of midwives throughout her pregnancy, birth, and early parenting period, always in collaboration with obstetric and specialist teams for consultation and referral. And this can be provided in community settings. We can have teams based in a hospital setting, normally to women with uncomplicated pregnancy. In some models, midwives provide continuity of care to women with social risk factors or from a defined geographical population. And if the women do develop complications, the midwives continue to provide their standard midwifery care alongside the partnership with obstetricians. In all models, the aim is for women to develop relationships with their midwives throughout their pregnancy, birth, and postnatal period. In both models, there is always collaboration pathways, consultation and referral pathways set up for higher levels of care. Next slide, please. We have women's experiences of continuity of care, and this for me is so important. And the evidence from women makes me proud to be a midwife. And I've put a couple of quotes here from our research in London in a community-based practice called LEAP. And I put the link to that in the slide, and there is also a video of women talking in that link. And this is a poster from WHO about how midwives can support women throughout their pregnancy. And for me, the most important thing is women often say, I felt respected, I was seen, I was heard, and I had someone advocating for me. All really hard things to do when she does not know who to contact or who her midwife is. Next slide, please. And we'll just put the slide in for the current evidence on the Cochrane review. There is much more evidence, and it's in the guidance documents. But this infographic can be very helpful. Next slide, please. So I'm going to hand back to Ulrika at this point. If you have Q&As, put them in the Q&A box, and I'll pass them through to the panel. Thank you.
Fantastic, Jane. Thank you. Yes, I think those statements from the women themselves, they are very emotional, and I agree with you. It feels good to read them as a midwife. Yes, so now I think we are ready for our panelists. So let me introduce all our panelists. So please put your cameras on so our listeners and participants can see you. Yes, we have Dr. Salomon. He is a midwife from Ethiopia. He has a master degree, and he has also a PhD in midwifery and women's health. And he's currently working as a ICM, International Confederation of Midwives, midwife advisor. So he's based in The Hague, in the Netherlands. Welcome, Dr. Salomon. I'm very happy to have you here today. So,
thank you so much.
I will now then go to Sweden. I will introduce all the panelists to you and to you audience, and then I will go into the discussion. So our next panelist is Dr. Annika Boman. She also has a PhD, and she's a senior research fellow, and she works at the Molly Bardagugu Institute for First Nations Birth Rights in Australia. Welcome, Annika.
Thank you.
And then we go to next slide, and we have Annika's colleague, Dr. Rhys McLean. She also has a PhD, and she's a senior research fellow at the same institute as Annika, and she will speak to her work on birthing on country. So welcome, Dr. Rhys.
Thanks, Ulrika.
And then we go to Dr. Sheila Clow. She's from South Africa, and she also has a PhD in maternal and child health. She's working at the Nursing and Midwifery University of Cape Town in South Africa. Welcome so much, Sheila.
Thank you.
And then we go to Professor Christine Robertson. Christine, she's from Sweden, and she's a professor in reproductive, perinatal, and sexual health at the Lund University in Sweden. Welcome, Christine.
Hello, everyone.
And then we have Leo Becker. She's a midwife and she has a master's degree. And she has previously worked with WHO as a JPO from the Netherlands. And she will speak to how it's working as a young midwife in the Netherlands.
Thank you.
So, thanks, Leo. I'm very happy for you to be here with me, and I would like to welcome all of you and for taking your time to share your experiences with us today and to share what you have learned transitioning to midwifery models of care. And during our discussion, you can ask questions in the Q&A box again. Just put them there, and then we can try to answer to as many as possible. We will also have a time allocated at the end to your questions, so we can pick them up then as well. So let's start with Salomon. Salomon, I know you have worked for many years as a midwife in Ethiopia. And you have worked on the national transition to midwifery models of care. And I think it's even continuity of care. So I would like you to share with us, what was the problem you tried to address with setting up your model of care? And also, can you explain to the audience how your model is working, how it's organized in your setting? So you are able to meet women's need. So I give over to you now, Solomon.
Yeah, thank you so much, Rorika, and happy International Day of Midwives. And I'm really happy and honored to be part of the panelists for this webinar organized by WHO. The types of midwifery model of care we want to test in Ethiopia started since 2019, almost 6-7 years ago. So during that time, the evidence was clear. During that time, there was a high-level randomized controlled trial studies that has been done in high-income countries, and all the evidences constantly showed that implementing midwifery model of care really improves the maternal neonatal outcome, maternal satisfaction, and other related outcomes. So during that time, in my country, Ethiopia, the maternal mortality was around 412 per 100,000 live births. And the neonatal mortality was almost 27 per 1,000 live births. And the institutional birth attendant was almost around 48%. You see, 52% of pregnant mothers gave birth at home. You see? So with all these kinds of problems, when I see the literature, okay, if implementing midwifery model of care really improves the maternal neonatal outcome, why not we test and see how it works in Ethiopia? Because when I search for the literature, I can't find during that time any literature implemented in lower and middle income country, the same context like Ethiopia. Okay, so the context might be different. So yeah, we know that midwifery model of care works in high income country, but since we don't have any literature that shows as midwifery model of care works in lower income country, that was my reason or our reason. Let's test and see how it works and how it really improves the maternal neonatal outcome. Besides, we had a high rate of maternal mortality, high rate of neonatal mortality, low institutional delivery, and during that time, surprisingly, the antenatal care coverage was high, but the dropout rate after a woman having 1 or 2 antenatal care follow-up, the dropout rate was around 40%. You see, those pregnant mothers who start antenatal care follow-up, dropout, around 40% of them were dropout from the antenatal care follow-up. So with all these problems, That was the reason. So let's see how it works and whether it can improve or not the maternal neonatal outcomes. Surprisingly, we found a very promising results. It improves the maternal neonatal outcome, the antenatal care coverage, the nutritional delivery, postnatal care. So this was the reason. You see, so I personally I found this a very important and kind of very important model of maternal health care for those countries who do have really high rate of maternal mortality, neonatal mortality, and sometimes there is also an issue of over medicalization. Especially in the urban areas of my country, the over medicalization is also becoming a major problem. The cesarean section rate becomes high, especially in the big cities of Ethiopia, like Addis Ababa and the regional cities. And when you go to the rural parts of the country, the cesarean section coverage is low. Those who need really to have a cesarean section may not have access to have cesarean section. But those who do have the access for cesarean section also had the higher rate of cesarean section. They may undergo cesarean section without having a clear obstetrics indication. So with all these problems, implementing and testing midwifery model of care was really worthy for us. That was the main core problem that initiated us to start implementing midwifery model of care. So the types of midwifery model of care we test was continuity of midwifery care model. So during that time, we select 4 primary hospitals in Ethiopia, and we categorize them, 2 of them as control hospital and 2 of them as the intervention hospital. So in the intervention hospital, we group 16 midwives, 8 midwives in each hospital, and we group them into a small team of midwives. Then we give them count number of pregnant mothers to follow until the end of the postpartum period. So we recruit low-risk pregnant mothers starting from the first antenatal care visit, and we deploy these pregnant mothers, or we assign these pregnant mothers to this group, so small groups of midwives. Then they start following these pregnant mothers starting from the antenatal care up to the end of the postpartum period. And we measure the antenatal care related outcomes, intrapartum care related outcomes, postnatal care related outcomes, maternal satisfaction, and all other important outcomes. And we compare to the control hospitals for those midwives who work in the already existing model of maternal health care. We call it the traditional or the shared model of maternal health care. So the types of model of care we test in Ethiopia was midwife continuity of care model, a team-based midwifery model of care. Why we select team-based midwifery model of care? Because the number of midwives available in Ethiopia to population ratio is not up to the WHO standard. So we have shortage of midwives. So we are not in a position to select a case load midwifery model of care. Like you said, Alrika, we do have a different types of midwifery model of care, but since we need to contextualize based on our country, so we contextualize and select, and we found as team-based midwifery model of care as the best appropriate model of maternal health care in the Ethiopian context. You see? So that is the scenario what we test so far in the Ethiopian context. Yeah.
Thank you, Dr. Solomon. It's super interesting to hear, and we will come back to you, but thank you for sharing. So let's now go to Christine. Christine is from Sweden, and we know that Sweden has a long tradition of midwifery care. But still, midwifery models of care where the midwife is the main care provider is not so common as we could believe in Sweden. So we would like now to hear from you. What is the problem that you are trying to solve? And because we know that the maternal mortality in Sweden is not the same like in Ethiopia. So I believe your goal is something else that you want to reach. And could you also talk a little bit about the model, how it's organized in your setting? So I give to you now, Christine.
Thank you so much, Ulrika, and thank you for this very nice presentation from Ethiopia, and welcome to Sweden and happy International Day of Midwives. So I'm Christine Rubersson, and I work in very south of Sweden in Malmö. That is the 3rd largest city in Sweden. So next slide. And our model is a continuity of midwifery care model. We have 2 teams of midwives working together, and this picture is the AI thinks that Swedish midwives looks like this when they're working in team midwifery, smiling and happy. And our target groups of women, it's women with fear of birth, women with mental health problems, and women with language barriers. So next slide, please. And our maternity care in Sweden is a very high quality overall, but it is fragmented during pregnancy, birth, and the postpartum. So we wanted to support vulnerable women with a continuity of care model, and we wanted to reduce unnecessary interventions and increase positive childbirth and breastfeeding experience. Next slide, please. And this is how we designed our model. Every woman is assigned a primary midwives who work in a team of 4 midwives. And to increase the likelihood of having a known midwife assisting at birth, the woman meets all 4 in the team. And that could be during antenatal care or parental education. And then the midwives, they are responsible for their their women. And they are on call 24/7, and they have availability by phone, and they are also on call in their home and work in a shared model of care with obstetricians if complications arise. Next slide, please. And in contrast to standard maternity care, we have designed our model with home visits. So we make a home visit during antenatal care. Very often it's the summary in pregnancy week 35, 36. And then we can also give assistance during the latent phase for premippers, women at home, and also during the first postnatal week. At birth, we give 1-to-1 care and assist our women during labor and birth. The postnatal care could either be in home care by my midwife or in hospital. And if it is in hospital, my midwife visits their women every day. And then we offer a checkup at 6 to 8 weeks postpartum, including contraceptive counseling. Next slide, please. So far, we have very preliminary result, but they show a reduction in the cesarean section rate for women with fear of birth when we compare to standard care. And the women, they report a high degree of availability and trust, both trust to the midwife and trust to the model, and they value the relational aspects of care and pay high importance to the home visiting program. And they also report a higher degree in involvement in their own care and also describe increased breastfeeding support. And then I tried to put together the top 3 practical recommendations for the other countries or for other groups to start scaling up the continuity of midwifery care. And that is, you have heard before that one size doesn't fit all. So you have to design the model to fit your local context. And in Malmö, we had very good experience with our home visiting program postnatally. That's another midwifery model of care that we have in Malmö. So when we designed the continuity of care model, we put in the home visiting program into our model. And then I would also like to emphasize to promote women's ability to self-refer. because you can't solely rely on other health professionals to refer, because not all of them recognize the positive effects of continuity of care. And then to work strategically with media. That's so important with communication. And then the next slide. I would welcome you to Sweden and Malmö, where the midwives are biking in rain and shine. Thank you so much. Over to you, Ulrika.
Thank you so much, Christine. It's super exciting to see how your model in Sweden works. And I think I like what you said, that you compare midwifery models care to standard care. And in standard care in Sweden, midwives are also working. It doesn't mean that
No,
it's
you're
a
very right.
different model. Yes.
Yeah, in the standard care is very fragmented in different pieces. Pregnancy in one piece, birth another, and then the postnatal period.
Yeah.
And when you have this fragmented care, you lose a lot of the positive effect that you see when you have continuity.
Yes, and I think that's the same that we heard from Ethiopia, that they drop out from the antenatal care. But when they were more likely than to go when they had this known midwife, they knew who they were going to meet and so on. Yes, Jane, over to you.
Christine, there is a question. Is your model covered by state insurance, or do the women have to pay?
Yes, it is. You know, in Sweden, the maternity care is tax paid and free of charge for all women. Yes.
But still, your model is not yet open for all women. You had that criteria that they were for a special group of women, right?
We need our politicians to go for it. Still, it's very, very few women who has the opportunity to get continuity of care in Sweden.
Yeah. Thank you, Christine. So let's now then go to South Africa and Sheila. So yes, I know that in South Africa that you have been exploring different midwifery models of care and to transition. Because the transition is meaning that you can always improve. You can always improve and improve the quality of care within your model. And I would like you, Sheila, to share what problem you tried to solve with your model in South Africa, and also explain a little bit about how your model is working, so that the listeners can learn also from South Africa. So over to you, Sheila.
Thank you, Ulrika. We have a number of different models that are evolving, but the start was back in 1973, which was completely driven by financial concerns. There was pressure on beds in the hospitals, and some thoughtful obstetricians realized, actually, we've got some brilliant midwives here, and we've got women here who do not need to be having hospital births. Can we not do something about it? So really, finances was one thing that was driving it. Another thing was that due to the apartheid policies, a number of people had been displaced from the areas where hospitals and healthcare was available to quite distant areas. So transport was difficult. So access became another issue. So those were two critical issues: finances and bed space, and transport. And so the target at that point was really to look at people of lower socioeconomic groups who'd been displaced from the city or the areas where there were resources, to make it more accessible to them and cheaper for them, so that they weren't having to pay huge transport fees, lose a day of earnings, and all of that sort of thing. But at the back of it was this belief that not every woman needed to give birth in hospital, and that midwives were the most appropriate people to be offering care to women with normal, healthy pregnancies. So, you know, I do want to give a shout out to those people who champion us as midwives, and it's one of the things that we do need to look for. So the initial setup was a very humble house in a residential area that was customized a bit to manage, a place for an examination, an assessment, and a birth. And I think it was staffed by 3 or 4 midwives who lived in the community, known to the community. So it was very organic in that way. And it worked so well that within 3 years they had opened 3.
Imagine, yeah.
In that 3-year period, they were doing 22% of all the births in Cape Town. And when I say
Really?
the births, I mean the whole pregnancy care, because it's everything from
Yes.
antenatal, labor and birth, postnatal at that stage. And added to that, they were offering at that stage home visits to all the women who gave birth with them, but also home visits to all the women who gave birth in hospital. So it actually gave value to people in hospital who required secondary or
Exactly.
tertiary care, but were followed
Yes.
up at home. Now, that had to fall away, sadly, in the 1980s when there were very high levels of violence, and midwives were simply not safe to be on their own at all hours of the day and night in the community. But we made arrangements that people would then be able to come into the centers. We call them midwife obstetric units. I know it sounds like a crazy name because we're more than that, but that's how we know them, as MOUs. And they offer 24/7 service. So they're available all the time, a community resource. And I think the fact that one sees this huge uptake within a short space of time, that people felt comfortable about coming to those services. It was accessible and acceptable to the women. And what it did to the medical establishment was for them to realize, gosh, this is safe care. This is something we have confidence in. And in fact, the perinatal mortality rate was half that of what was in the hospital. Our perinatal mortality rate in those first 3 years was 6 per 100 per thousand, which we're nowhere near at the moment, but we did reach it at that point. So that was
Yeah.
one driver around the public sector. I want to just mention another driver amongst the independent midwives, those who chose not to work within the within the public sector. I'm sorry, I've just found that my battery is running low. Will you give me 1 second?
Oh, yes, 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 yes.
Sorry,
It's okay, Sheila?
we had somebody ride into the electricity supply last night, and we were rather disrupted.
No worries.
Could you give me a break and come back to me?
Yes, I will go to Australia and then we come back to you, Sheila. Don't worry. You sort out your technology issues there and we go to our colleagues in Australia. So we have Res and Annika from Australia. So I know you are both working on something that is called Birthing on Country. So I give over to you to start informing us what is it and what was the problem you wanted to solve. So over to you.
Thanks, Ulrika. We really, really appreciate the opportunity to talk to you about Birthing on Country today. As part of my cultural custom, I'd like to start by acknowledging that I'm on Whadjuk Noongar country in the southwest of Australia, and I want to pay my respects to elders past, present, and emerging. And I also want to acknowledge that here on this continent, Aboriginal midwives have practiced and cared for women and babies, and that has allowed us to be part of a culture that is 60,000 years old. And that could not have happened without skilled midwives. I'm not sure if it's possible to share the slide of Molly Wadaguga. So Annika and I work at the Molly Wadaguga Research Institute at Charles Darwin University, and we always acknowledge Molly in everything that we do. Molly was a midwife, a senior Aboriginal woman, and an Aboriginal health worker. And Molly lived in a very remote part of the country, miles away from any hospital. And she had a dream for birthing to be returned back to her community. So in her lifetime, she saw birth taken away from her community, and she was always on a mission to bring it back. So everything that we do, we want to acknowledge Molly's vision, and we work for that. Thank you. You can take the slide away. Thank you so much. So I guess it's really important to recognise that Indigenous women globally experience perinatal health outcome inequities that stem from colonisation, dispossession of self-determination, and medical racism. And so in Australia, for 40 years, Aboriginal and Torres Strait Islander women from across the continent have really expressed their struggles with the dominance and expansion of a Western-style biomedical health and maternity system. This system was not designed for us, and it has not achieved health equity for our people. And so Birthing on Country services aim to return control of maternal and infant health services, including birthing, back to First Nations community control. Evidence tells us that when services are run by First Nations communities for First Nations communities with genuine partnership between government services and hospitals, outcomes are better. So the problem that we aimed to solve is that this is really about healing from colonisation. It's about the reclamation of culturally appropriate birthing and maternal and infant health services, and for them to be based in communities. I'm really happy to talk a little bit about what a Birthing on Country model looks like. I do have another slide, Amanda, thank you, which kind of lists that. And I'll go through that. But just to give you some context for Australia, so we have the maternity care classification system. That's our way of organising and measuring models of care in Australia. And so in our country, the most common, like it sounds like in Sweden and other places, the most common model of care is public hospital care with varying degrees of continuity provided by midwives and obstetric trainees. Women don't have 24 access to a known care provider, and likely she will be cared for by midwives and doctors who she's never met when she is having her baby. Yeah. Often midwives do not work to their full scope of practice either when they're employed by the hospitals. So caseload midwifery is about 14% in Australia of women. And we also have privately practicing midwives. So about 2% of women in Australia have access to a privately practicing midwife. They are midwives that have undertaken extra study to work in their full scope of practice. So prescribing medicine, ordering ultrasounds. They do not need a doctor's referral to work with women. So the other thing I just wanted to mention before I talk to these points quickly is that in Australia, we have what are called Aboriginal Community Controlled Health Organisations. They are primary healthcare services that are governed by Aboriginal communities to deliver culturally appropriate care. They exist because the mainstream systems have often failed to meet the needs of my people. And by being community-led, there is more trust and engagement. Now, many of these Aboriginal community-controlled health organisations, I'm going to call them ACCHOs because it's easier to say, they provide antenatal and postnatal care, but the women still have to go to the hospital and birth with unfamiliar caregivers. So ACCHOs don't usually provide birthing care. There are only 3 ACCHOs in the whole of Australia, just 3, that provide birthing care as part of their Birthing on Country service. So Birthing on Country, it means a few different things. For us as Aboriginal people, country means more than just land. It's a living being. It's our mother. We belong to country. It's also where our ancestors have been for 60,000 years. So Birthing on Country does not mean that women go and give birth in the bush by themselves without any help. That's not what we mean. Birthing on country means the best start in life for Aboriginal and Torres Strait Islander babies. It's a social justice movement to return services back to our communities because we've lost control over our birthing services. And it's all about respecting our sovereignty, which was never ceded to the British Crown. So it's really about human rights. So then birthing on country services are specific models of care underpinned by that philosophy. They go beyond standard hospital care, which often harms and hurts our women. And they're even different to hospital-based continuity of midwifery care models because they combine cultural, community, and clinical elements. So in simple terms, they are maternity services designed with or by First Nations women for First Nations women. And they incorporate all of these different things that you can see on the screen. Relationship-based care, continuity of midwifery care is essential, but it's not the only thing. You need, holistic programs for the whole family, trauma-informed practices, our ways of knowing, being, and doing. And these services, we hope, are community-based and run by the community, not by the government.
Thank you, Res. Thank you.
Thanks.
Thank you. Thank you so much. I think we will come back to you, Annika and Res. Let's go to Leo, and we can hear from the Netherlands how I know that you have so many different midwifery models of care in the Netherlands, but it would be like I would like to hear from you as a young midwife working really and providing care. So I would like to hear your perspectives on midwifery models of care, and maybe you choose continuity of care. So let's over to you, Leo.
Yes, thank you so much, Ulrika, and happy International Day of the Midwife for everyone. Yes, I will elaborate a little bit on the maternity care in the Netherlands. And the Dutch maternity care is centered around midwives. And it follows a midwifery model of care, a continuity of midwife care as well. That means that in primary care, midwives are the main health provider. They are working as autonomous practitioners. They are the lead health provider for women with low-risk pregnancies. And it's a little bit similar to what we heard about the Swedish system. Most midwives, they organize themselves in teams. And this same team of midwives, they're located in the community, and they take care of women throughout antenatal period, intrapartum care, and postnatal care as well. So 90% of women in the Netherlands, they start in primary care, and they have their first appointment with the midwife. And if then turns out that it is a high-risk pregnancy, or if somewhere along the way complications arise, then the midwife refers them to secondary care, and the secondary care follows an obstetrician-led approach. So in summary, midwives take care of low-risk pregnancies during antenatal, intrapartum, and postnatal periods. And what I want to highlight a little bit is the impact of this model of care, and not only for the women, the patients, but also for the health providers, the midwives. And during previous presentations, we already heard about the positive health outcomes for women and newborns, and also enhanced experiences of women. And I would like to highlight the experiences of midwives in midwifery models of care and continuity of midwife care, because it definitely has a positive impact on them as well. Evidence has shown that midwives practicing within midwifery models of care have an increased job satisfaction compared to midwives working in other models. For example, we see lower levels of burnout, anxiety, and depression as well. And well, you already mentioned it, Ulrika, but I have worked in the Dutch midwifery models of care with continuity of midwife care. And I have had the pleasure of supporting women during the delivery whom I already met during several visits during the antenatal periods. And yes, I think the experiences that brought me the most satisfaction are the experiences where I already established a relationship with women, where I could build upon during the delivery. And these experiences are also where I still remember the names of the mothers, where I still remember the names of the babies. And these are the highlights of my work as a midwife. I also feel like I could really add to the quality of care, as I could, well, better estimate what the needs of the woman were during the delivery, because I already had that relationship with her. And then in the postnatal period, after supporting their delivery, you always try that the midwife who attended the delivery also visits the woman during one of the postnatal checkups. You help the woman to process the birth, you answer questions, and you see the new family taking the first steps, well, as a young family. And I would say that the icing on the cake is always when a woman comes back to the same team of midwives in her next pregnancy.
Yes.
And
Yeah.
I have been lucky enough that I happened to be the midwife on call during a second delivery of a woman where I
Imagine.
did the first
Yeah.
delivery.
Yeah.
And those are just very, very special moments. You already have an established relationship that you can build upon. And yes, I can say those are very cherished and special moments in my career as a midwife. And I also just want to focus on that nowadays the world is facing a shortage of midwives, of nearly 1 million midwives we need. And these shortages are across all regions, geographical regions, but also across all country income levels. And what contributes to these shortages is that midwives are leaving the profession. And this can be due to various reasons. Of course, training more midwives is part of the solution. But I also think that we should focus, and governments should also focus on keeping midwives in their profession. And of course, financial compensation and professional recognition are important factors. But job satisfaction is also a very important factor.
Very important. Yeah.
Yes, and I have experienced and evidence has shown that midwifery models of care adds to the job satisfaction. So in summary, midwifery models of care don't only have positive impacts on women, the newborns and their families, but also really on the health providers. And I just wanted to highlight that a little bit.
Thank you, Leo. Thank you. Yes, yes. Very, very interesting. Thank you for sharing. And this is so important because we have received so many questions about midwives having burnouts and heavy workloads and so on. So this could also be addressed for those kind of challenges.
Definitely.
You know, when you have fun, time goes fast. It's already 11, 5 minutes past 11. So I think we will go back to Sheila because she had some technical problems. So thank you so much, Leo. We go back to Sheila, and maybe Sheila, you can share a little bit about the challenges that you had in South Africa. I mean, you touched upon some of them already, but in recent times, what are the challenges that you have had to transition to your midwifery models of care, and how did you overcome the challenges? So over to you.
Thank you. Well, I just wanted, in my previous slot, I wanted just to underscore the fact that despite having different models, we offer a full spectrum of care from antenatal through to postnatal and neonatal. And that has been able to extend because it is now a hub of resources. So we've now introduced perinatal mental health care. There's phototherapy for neonatal jaundice if necessary, so babies don't have to go to hospital. They can stay at, close to home, including kangaroo care, all of those sorts of things. It allows us to show our value to the community as well as to the health planners. So they start seeing this as a win for them. And I think that's one of the challenges that we always need to be looking at. How can we make sure that we target different audiences and show how we, as midwives offering midwifery model of care, create a win for them So the health planners want to see safety and they want cost effectiveness. The community wants to see accessibility, availability, and kindness and respectful care. The midwives want to see a place that is well stocked, that they know who their patients are, that they are going to be backed up when they need it. So I think we really need to be saying it's not a single message that needs to go out, but find the right message for the right audience who's going to help become your champion for that. So, for example, when we were setting up like a private-public partnership between independent midwives who were only able to offer home births because they were being shut out of the private hospitals, we said, well, we can offer this on a public sector site that is separate from the rest of the hospital, but you'll have access and you'll have backup. So it meant that the women had more choices, that they could say, I want to have this, my own midwife. I'll pay for them independently, but I know that I've got the option of having something that is an alongside type of birthing unit if I want it. So I think that would be one of my big points, is make sure that you target the message for the people who are going to support you. Another particular issue, I think, is around the guidelines and referral criteria. Make sure that we're all singing from the same song sheet, that the expectations of the midwives, of the clients, and of the medical professionals are the same. That we know that we're not going to be offering Caesars in a freestanding birthing unit, for example. So that is clear. And then that is abided to. So we have developed the clinical guidelines with a multi-professional team, obstetricians, midwives, nurses, and neonatologists. And we know that if somebody calls in to say, I need a referral, they are confident that that referral is going to be accepted. And we have the backup from the neonatologists or the obstetricians who will say to their junior staff, do not deny a midwife a referral if she asks for it, because she knows what she's talking about. It's our job to provide the further level of care. And it's that level of support that is so important. I've seen some questions around how do we get through this when we are so dominated by the medical profession? And I think if we can find ways of making partnerships that's going to serve their aspirations as well as ours, that can help us. So guidelines, in fact, I had to send through a slide on referral pathways that might be useful just to put up here. And while I'm talking about that, there's the other issue of cost. So you can see here in the yellow level is what we talk about, the MOUs, the midwife obstetric units, essentially, where we're offering full continuity of care for pregnant women. And they would refer directly to a secondary hospital if there was an indication, and in some cases might refer directly to a tertiary level hospital if the referral warranted it according to what we've previously agreed on. So I think those are some of the key things. Obviously, you need to have an adequate workforce, and critical to that is a workforce of midwives who are supported, who get ongoing training. I saw one comment earlier about saying we don't feel confident enough to make clinical decisions. Well, I think the educators really need to get involved there and call in the people who are going to assist you with that and run essential steps of midwifery, maternity obstetric emergencies and neonatal emergencies, so that people have the confidence to do that. And then everybody wins. The midwives feel more empowered. The clients feel that they have got a service that they can trust. The doctors feel they can trust the midwives, and people stay closer to home. So I think I'm going to stop at that point.
Thanks, Sheila.
I could say, but other people want to say things, I'm sure.
Thanks. So we have so many questions from the audience, and I know there are many questions on how do you start to set up the model? How do you start the transition? Because you might or you may not have midwives in your country. But maybe we can hear from Annika a little bit about this policy. We haven't heard from Annika yet, so Annika, I give over to you.
Thanks, Eureka. So in Australia, some of the challenges that we've faced have really echoed what we've been hearing from the panel. So we really have that struggle with implementation where policy and government aren't really having that buy-in into the models of care and that supportive environment. So at the Molly Wadaguga Institute, we really took that by the horns, and there have been 2 national gatherings with community, and we have facilitated the voices of First Nations peak bodies, community members, service providers, midwives, in shaping the birthing on country models of care. And what came out of that was this implementation framework that you have on the screen, the RISE framework. So we found that services have 4 areas where they want to really invest and drive that national implementation, which is redesigning the health service, investing in the workforce, strengthening families' capacity, and embedding community control, sovereignty, and ownership over the model of care. And that's underpinned by the Dreaming Country and First Nations Aboriginal and Torres Strait Islander law and ceremony, which are at the heart of these models of care. So we made sure that government were involved in every step of the RISE framework development, and also the workshops driving the national implementation work that we did thereafter. There was a 10-year gap between the first and the second gathering, and there was a real frustration across Australia nationally that implementation hadn't been rolled out quicker. And so the Molly Wadaguga Institute again took the lead with that and developed the roadmap with community organisations, with strong partnerships with services and art shows nationally, and made sure that we had clear short, medium and long-term goals that government needed to follow to implement the national upscale. We're really fortunate in Australia that we do have an enabling policy environment with the Close the Gap priority reforms. And in the latest report from the Close the Gap, the outcomes were really disappointing, honestly, but there was a real strong impetus to hand back control to community for implementation. Because we know, as Rez said, for 60,000 years, traditional birthing models have been successful, and now we need to make sure that we give that control back to communities because they know how to implement it nationally. They know what their community priorities are through engagement, and that's how we use this framework that you see in front of you to build those models of care that are built on the priorities of community and respond directly to the community needs. And continuity of midwifery care is a core foundation of these models of care, but it's a wraparound holistic service to support not only the families and the community, but the midwives as well that are working in these models.
Thank you. Thank you so much, Annika. So I have been got support from Jane on some of the questions and that you have put in the Q&A box. And I think we have one question for you, Solomon. It's really about how do you decide what to do when there are competing priorities, and how do you also provide your strong evidence to have this political change. So over to you, Solomon, to tell us about how you decide what to do when there are competing priorities.
Yeah, thank you so much. With regard to the implementations of midwifery model of care, I think it's advisable and better to give more priority for the implementations of midwifery model of care. Besides, we have other competing interests because implementing midwifery model of care will support and help countries to easily transit and improve the quality of midwifery care as well as improve the maternal and neonatal outcomes. But when it comes to the context of lower and middle income country, for example, there might be some priorities. Yeah, the number of midwives might be, for example, short. The number of health facilities available in the country might be short, so that access to health facility might be limited. So with all these things, what we found from my experience is, yeah, with all these constraints, if there is a commitment and if priority is given to transition to midwifery model of care, a really midwifery model of care can be implemented with all these constraints. You see, even though, I saw some of the comments, low number of midwives or shortage of midwives might hinder the implementations of midwifery model of care, but still with that number of midwifery, with that number of midwives available in each country, still they are practicing, they are providing SRM managed services. So what makes midwifery model of care is different, or what makes it unique to implement midwifery model of care with already available number of midwives in each country. So my suggestion is, yes, we can start implementing midwifery model of care even with the existing number of midwives in the countries. And based on that, then we're going to see how it will scale up and improve with that conditions. The other thing, with competing interests, there might be a competing interest with other healthcare providers, but still we encourage our midwives to work with interprofessional collaborations. One very, very important thing we need to clarify is when we say midwifery model of care, it doesn't mean that it is only midwifery. It includes all other important healthcare providers who are really working and engaged in the RMNSH service. So, but the thing is, the woman needs to have one known midwife whom she will going to consult, call, or had a contact with them. Otherwise, other healthcare providers needs to have also collaborate with midwives to provide the service, especially obstetricians, pediatricians. They are really very important and they need to collaborate. For that, for example, when we scale up the implementations of midwifery model of care in Ethiopia, currently we also group midwives in a small team, but we also assign one named obstetricians whom the midwives will directly contact or communicate if there is any complication or if there is any need to see the woman by the obstetricians. You see, so these kinds of interprofessional collaboration is also really very important. Policy change is another very important issue we need to consider. We need to prioritize.
Yeah.
That's really one very important challenge that challenged us when we start implementing midwifery model of care in Ethiopian context was the absence of local policy or guideline that recognize midwifery model of care as a model of maternal health care was a challenge. You see, so with the absence of policy and guidelines, local policy and guidelines, implementing midwifery model of care might be a challenge. So what I advise and prioritize is you need to prioritize on policy analysis and policy dialogue. So the evidence is clear. It's scalable. It is adaptable to every country. We have midwives in every country. So what is remained? So the discussion needs to come from each country. The interest needs to come from each midwife. The other thing, we need to also increase the knowledge and the skill of our midwives on how to work and organize themselves to work and implement midwifery model of care, because it is a new concept, to be honest. So for those midwives who are employed and work in the health system, they need to take some kind of refresher training, some kind of skill and knowledge training that will help them to integrate and able to work with midwifery model of care. That's really very important. But when we think largely, we need to also try to include the concepts of midwifery model of care even in the midwifery curricula, so that the new generation will have the chance to train about midwifery model of care, and so that it will be easy for the young generations to easily adapt and work with midwifery model of care. So all these things might be very important we need to consider, but always there will be a priority. But for me, it's time to prioritize implementations of midwifery model of care for those countries who do have high rate of maternal and neonatal mortality. It is time to transit our healthcare system to midwifery model of care. The evidence is clear.
Thank you.
Thank you so much.
Thank you so much, Solomon and the other panelists. You have all touched all the 8 transition areas that we present in the implementation guidance: the women and community engagement, the education and the continuous professional development, the leadership. I have seen question about leadership and research, the service provision, the health system strengthening, and other transition areas. You have policy and guidelines, of course. So you have touched upon all of those ones. So please go to the transition framework that is presented in the implementation guidance. And I see that it has been put up there also in the chat. And as I mentioned, we will share them after the webinar. We will share them with all of you. Jane, we just have 10 more minutes. It has gone so fast. Do you have any burning questions there that you want to bring up to the panelists before we come to an end? Jane, over to you.
There is a question about the birthing on country models and how you support women with mental health problems.
Yeah, thanks, Jane. So, yeah, in Australia, because of colonisation, Aboriginal women do often have higher psychological distress, life stresses, and no one size fits all. But actually, what challenged me and my Western midwifery training is that birthing on country models actually decenter the midwife. For an Aboriginal woman, a non-Indigenous midwife cannot be her be-all and end-all. And so that's why midwives work in a wraparound service. And birthing on country services have got formal strategies to engage families and strengthen families, because who's going to look after that woman after 6 weeks postnatal? You know?
Yeah.
We have, so it's really about strengthening culture and, of course, working in the multidisciplinary team. Sometimes Western medical intervention is required, and so you might have psychological or psychiatric input, of course. But for us, culture is foundation and connection to country is foundation. So sometimes it's just about taking women out on country, painting her up and smoking her with Aboriginal women. So it's cultural and clinical. And I guess I'll stop talking, but it's really about decentering the midwife. She's one of a team of many. Yeah.
Thank you, Rez. That is so important that midwives are the gateway to many other types of support. And you are so right that after 6 weeks, we're not there, so we have to prepare those pathways. There's a slide, Ulrika, about evidence gaps, and I'll just sort of summarize that because we don't know everything. And what I've put up here is what we still need to find out. And this is in high income and low income countries. So we have said that one of the most important things is the relational practice, it's relationships of trust and avoiding fragmented care. But we haven't really seen how these models can impact on women who have the worst, in the worst circumstances and the worst outcomes. We haven't done much research on women who do develop complications, who still need midwife care, but end up with fragmented midwife care. Scaling up and implementation research in low and middle income countries, really important to have more research. And there have been several comments here about the acceptability to midwives of working in different models. We need to look more at that. And surprisingly, we haven't really defined and measured continuity terribly well in the research that's done. And we need to do more cost effectiveness evaluation. So I think if you can finish there is another slide on birth centres. We really need to update the research on the birth centre midwife unit research. It's terribly out of date. And then again, more implementation research. So I'm going to finish there on research gaps. It's been what we tried to do in this webinar is listen and learn from people who we haven't listened to before from the Birthing on Country model, which is so inspiring, I think, for many people in high-income countries, from Christine in Sweden, from learning how Holland is developing its work, and particularly from Sheila in South Africa. We will put links in the slides. So we will have to add these links as panelists so you can follow up on more detail on all this work. And I cannot resist adding that from our own research in the UK, in London, which was on a community-based practice with women living in low poverty, lowest postcodes. We have a wonderful video of women talking, and I'll put the link in the chat, and I'll add an extra slide so you'll get that. But it's just inspirational. And for me, it reminds me why I'm so proud to be a midwife and have the privilege of doing research in this area. Because at the very end of the day, we start with women and their experiences are crucial. And what they say in that video, I think, is what women would say in every single presentation that we've heard from. So I think I'll stop there, Ulrika, and I'll hand over to you.
Thank you so much, Jane. And as we close, I really also want to highlight 3 themes that I think has emerged from our discussion while I have been listening and learning from our panelists. So I think what we have heard today is that midwifery models of care it's not an abstract idea, or it's really being implemented in several and very diverse health systems, I would say, and also with measurable impact. We heard about impact that our colleagues or panelists mentioned, both for the woman, the newborn, the families, but also for the midwives themselves. And the second point that I took with me is about the policy and system change, that how important it is for policy and system change. And we heard that we need to adapt our messages to different stakeholders. We can't speak the same to regulatory bodies, to financing people, or to the educators. So we need to also adapt our messages. And the third thing that I have taken with me today, it's about continuity of midwife care, that it is a proven, and I would also say it's possible to scale it up. And what we have heard is also that it strengthens primary health care, and it eventually can advance universal health coverage. So with these 3 points, I would like to thank the panelists. Thank you so much from my deepest heart. And thank you to Professor Jane Sandel. Thank you for co-hosting or co-moderating this panel with me. And thank you also to Alison and Dr. Tedros for his message, and to all of you that have joined us here today. So you can see there on the last slide that we have that remember that evidence alone is not change care. The implementation through our collaboration, it will make the change. So let us work together and to make this continuity of midwife care and midwifery models of care the standard, not the exception. And we look forward to continue discussing with you and to work with you. And I'm sure you will look after my email with all the resources and the link to the recording. So, and we can also, if the panelists, we can share, contacts so people can continue the discussion after this webinar. A huge thank you again, and wishing you all a lovely International Day of the Midwife. Thank you, everyone. Bye-bye.
Bye-bye. Thank you.
Thank you.
Thank you. Bye-bye.